So, yep. Oh, go back one. That's fine. So, yeah, Cure Today, Cure Tomorrow, Care Today, I think is a very good sort of baton to hand over, because when we look at the projects we have being discussed around the table this morning, there's obviously a clear emphasis on Cure Tomorrow. I think every project we're doing is trying to look at preventing this dreadful condition, but I think we have to be cognizant of the fact there's still millions, tens of millions of people living with the experience of dementia, and there's massive unmet clinical need, and a lot of research improving their quality of life is absolutely needed. So in the next, that wasn't a very sort of upbeat, exciting start, was it? To be entertaining. So what is Alzheimer's disease is what I'm going to talk about a little bit. I was given the title, give a lecture on Alzheimer's disease. That's got quite a blank canvas. I can go a lot of different directions with that. But I thought as a starting point, I'll have a little think about what is Alzheimer's disease. Number two, what are the key challenges we face in terms of Cure Tomorrow, if you like, and how can the IMI AD platform address these challenges? When we talk to patients or clinicians or indeed the public, I think they've got a pretty clear understanding what Alzheimer's dementia is. It's a memory disorder with another cognitive domain affected, which has an impact on function, and it inevitably declines. I don't think there's much challenge in the sense of being able to make a diagnosis or understanding what Alzheimer's dementia is. The problem lies when we actually start talking about Alzheimer's disease, because people ask, are they the same thing? Are they separate entities? And the way we're communicating the distinctions, if there are any, between Alzheimer's disease and Alzheimer's dementia, is actually one of the challenges we face. But what I've been doing over recent weeks when I've been doing lectures like this, I've actually been doing a sort of ask the audience type quiz. If you were to think of Alzheimer's disease, or a person with Alzheimer's disease, and I'm actually going to ask you to vote on this, who do you think of? Do you think of a young child? Do you think of a young adult? Do you think of somebody in midlife? Or do you think of somebody in late life? Who thinks of a child when I say Alzheimer's disease? Nobody. Young adult? Somebody in midlife? I was hoping it'd be everybody. And late life, the rest. Okay. So I'm actually tempted to actually sort of write these results down and see if there's a trend towards moving towards midlife as being the associated age of Alzheimer's disease over the next few years. Because a lot of what we're doing in the AD platform is premised on the belief that Alzheimer's disease is actually a disease of midlife, which expresses itself as a dementia syndrome and the end stages of that disease. Because if we don't believe that, then it kind of makes it hard for secondary prevention, because we have to be able to intervene in the course of the disease many years before the dementia syndrome develops. Now, I'm a clinician, so I'm slightly nervous about ever talking about biology, especially in front of this sort of audience. But let's imagine that in Alzheimer's disease in midlife or adult life, the pathologies, if we believe the amyloid cascade hypothesis, the pathologies are reasonably specific around amyloid and tau. And we need to be able to measure those in midlife quite successfully. But as we get in to later life and the disease develops, then we then see in post-mortem findings and biomarker analyses that there are lots of different pathologies which are contributing to the overall clinical phenotype. It's no longer just amyloid and tau, but it's cerebrovascular changes, it could be alpha-synucleinopathies, etc. And one of the challenges that we face is working out how all these pathologies actually interact with each other to drive the disease process forward, but also how they link to the clinical phenotype. And I think everybody in this room has seen this slide 1,000 times, but in some ways the way we were conceptualizing and thinking about Alzheimer's disease as being a disease of older people was possibly one of the factors which underpinned the failures that we've been seeing in terms of drug development over the last 20 years. Now, this slide is about, I think, 8 years old now, 2014, so 4 years old, 4 years old. But unfortunately, nobody's made it yet into that inner circle. So even with 3 or 4 years, there's nobody yet made it into the inner circle with a drug. So what we had to do was either think about this completely differently, the Che Guevara approach, and say, right, there's going to be a revolution. We need to think differently about the way we're addressing this. Or was it, University of Edinburgh graduate, Charles Darwin, was it more of an just threw that in. Was it more of an evolutionary process from where we were before to where we are now? And I think it's a bit of both. I think there came a point in time, I'm not sure where, there was a chief executive initiative in New York Academy of Sciences that said, look, enough's enough. You know, we're going down a track, we're doing it the same way each time we do a trial, we're looking at this disease the same way. There needs to be a little bit of revolution, a little bit of disruption, I think, in the way we think about things. And there's three visions, if you like, of these of evolutionary or revolutionary visions, if you like, for I think how we should be moving forward in the future. Number one, we have to truly believe, and I don't say believe, it sounds a bit sort of religious, we have to be bold and agree we can go earlier in the disease process. The reason I say that is because, like I say, the trials we've been doing to date have been in people with advanced Alzheimer's disease, even if it's mild dementia, even if it's prodromal dementia, they probably have very advanced disease, where the contribution to that clinical phenotype is from multiple different pathologies. So no wonder when you specifically knock down with a BACE inhibitor or a monoclonal antibody one pathology, you have very little impact on the clinical phenotype. So what we have to be able to do is identify those people in midlife and identify those pathologies, which are probably more in their infancy, to get them before they really dominate and then drive a significant clinical impairment. Secondly, we have to believe we can use these interventions well and effectively. And what this slide's trying to illustrate is maybe in the future we'll take a more sort of oncological approach to managing Alzheimer's disease in the preclinical population, where we'll measure the success of our drug exclusively on the presence or absence of a biomarker. We knock down the target, the biomarker drops, we stop the drug, they're in remission. If the biomarker escalates again, we start the therapy again. And that net effect of that is that the clinical syndrome doesn't progress as quickly. And all the time, of course, managing those risk factors which are manageable. Stop banging your head, stop smoking, lose weight, these sorts of things. The third vision is that we will truly be able to identify who is at risk by combining genetic and non-modifiable and modifiable risk factors, how they express themselves cognitively, not in symptoms, remember, these are pre-symptomatic individuals, and how they express themselves through biomarkers, and using all that fantastic data to create some really good, Martin, disease models or clinical models for disease which are robust, reliable, and accurate. And then those will be the people that we can target with our interventions. So, if we believe in those three visions, what are the challenges? What are the knowledge gaps which have to be overcome? Number one, what is the relevant biology? We've heard today from many projects which are trying to look at different mechanisms, different pathways that may be relevant in the genesis of Alzheimer's disease and then in Alzheimer's dementia. But how can we measure this in vivo? We don't do brain biopsies in clinic. We're always measuring these things at a distance through neuroimaging or through CSF or blood-based biomarkers. And how do they associate with the clinical phenotype? How can we measure cognitive symptoms better or cognitive impairment better in people before they become symptomatic? How do we intervene and measure success? If you've got a drug that affects the target, how do you measure its effect on that biomarker or indeed the clinical syndrome? How do we develop these probability signatures for individuals, the risk profiles? Who is it that we want to recruit into our trials? And how do we recruit and operate within a collaborative and ethical framework? A lot of the stuff that we're doing, particularly in EPAD, is very, very tethered to an ethical framework, in so much as what do we do with this information about disclosure of risk? And we spend a lot of time discussing this. We publish papers on it. We're collaborating with GAP and others in the US on this. And how do we critically, and Serge says this, it's for nothing if we can't get these drugs to the people who need them most. So how do we get these findings into practice, both at a clinical level for our drugs, but also if it's lifestyle interventions at a public health and policy level? So you've all seen this slide before. It's the slide I often use for EPAD, but it's as relevant, I think, for the AD platform. What do we need to do? We need to find huge numbers of participants. We either develop them in our cohorts like EPAD, or through EMIF and other projects. We bring together existing data sets, and we mine that data, and we create models from that. Number two, we have to measure people's brain health well in terms of their clinical phenotyping. And in EPAD, we've developed our own cognitive test battery, specifically around the preclinical and prodromal population. We need to understand that biology and measure and work out how to measure it in vivo and collect 1.1 million samples is the plan for EPAD over the next sort of 4 or 5 years. and make that available to researchers globally. We need to make sure we've got the best card-carrying statisticians in the universe working on these data sets, using novel, innovative modeling techniques with access to fantastic big computers. And critically, on this journey, we need to make sure we're taking the participants with us and the public with us. So we don't just find all these amazing results, publish them in the Lancet, New England Journal of Medicine, and wonder why the public hasn't come with us in the journey when we start talking about disease modification, etc. And I think what the IMI AD platform does, and the 10 projects that I've been listening to this morning do, is they bring all this together into one singular environment, the IMI AD platform. So, just to finish, this is a very sort of traditional approach to understanding a translational pathway. You start off in the lab, you do some sort of phase 1, phase 2 testing in a very refined, well-defined population. You then go into a broader population base before you then start using it in the clinic. And I must admit, I did actually do this talk in the BA lounge this morning, so sorry, I got a bit lazy, and I just stuck them all in at once. But this is where I thought you might be able to put each of your projects in terms of that translational pathway. Now, each of you looking at this are probably going, no, we're not there, we're there, or we're a bit over there as well. And I think that's the problem with the translational pathway, is it's not left to right. What we actually have is much more of what I call a translational environment, where you have forward to back translation from clinical research to fundamental research, also incorporating big data sets and the availability of knowledge from other sources coming into the fundamental research. So the forward translation from fundamental research could be a mechanism which needs a biomarker to be validated, or a drug that needs to be discovered, and et cetera, et cetera. You do the clinical research, you make findings, and then that reinforms or re-educates what happens in the fundamental research. So I tried again to put everybody somewhere on this. And then I thought, what I'll try and do is like a connectome. I'll try and join them all up to see where all the interactions lie. And I thought, well, that's not actually what we're all about. What we're about is a single platform. Because if we all act as isolated projects, then we're going to have all the difficulties that we're finding, certainly in EPAD, of what does a collaboration actually mean? It's easy to say we are collaborating, but what does that mean in terms of deliverables and actually moving the science forward? So what I called it was the European Translational Union. I was trying not to be political, but I failed. Okay. So anyway, final slide. So the key challenges to achieving the visions, and I think there's 3 key challenges. Number 1 is the scientific challenges, and they're numerous. But I think as we listen in this room, they're pretty well defined, and I think we've got projects to try and address some of those scientific challenges. But we have to accept innovations. So I heard, again, I'm going to say from the adapted, the disruption. Let's be open to innovation, and then let's bring that back into this translational environment, because these discoveries will raise new challenges, and we should embrace that and really look forward to addressing those challenges in the future. The second is engagement with the patients and the public, and that's where things like Roadmap and I was going to say moped study, it's not the moped study, but it's like the moped study, are really taking that bit of the journey forward, and obviously under the leadership often, or the contribution of Alzheimer's Europe. We're also not acting in isolation. I think it was Simon mentioned earlier how we interact with GAP and we interact with the Canadians, we're talking to the Australians and the Japanese. We're part of a global family of initiatives within IMI. And I think it behoves us to work very closely with these partners in making sure that we're working efficiently. But also each other. I think it's important we overcome the challenges of working together. We had a conversation with Martin and Anna Graf about eteonomy 2.5 years ago, about how we were going to collaborate. And we still haven't got there yet. The reality is we want to collaborate, but sometimes the challenges of actually delivering that collaboration can be not scientific. And these are the efficiency challenges. The numbers that Jean-Georges gave amounted to €250 million of investment in the platform. And to quote Simon, future generations will not forgive us if we do not use that €250 million well. How do we use these resources? We often say, oh, cancer research gets a lot more and HIV research got a lot more. Okay, let's do the best with what we've got. Let's minimize the inefficiencies in the system. And how do we do that? We do that, I think, ultimately through better coordination and leadership. So I'm going to stop there. I'm not sure if that's upbeat and entertaining or soft, but I'll invite any questions. So thank you very much.